Yeah, sometimes I see how many people have been admitted, but I don't see it yet. Okay. Hello, everyone. Should I just start with the introduction? Now I see 11 people joining, but there should be more. So let's take a minute or a couple of seconds to have everyone in. I see only 11, or are there more, Emily?
So far, we have 11 attendees, including us three.
Yeah.
12 now.
Yeah,
And
one more.
will be joining.
Hello. So maybe I'll just start with the introduction. Good afternoon to everyone. We are having the webinar of MTG7 of Endo-ERN. So you're at the right place at the right time, and I welcome everyone with a Happy New Year. I think today I can still say it. I'm Olaf Hirt, and I'm moderating this session from the medical part, and Emily White, who has just blinded herself, is the technical part from Endo-ERN. We are very happy to introduce our speaker, Heidi Klaassen. Before I introduce her, please, you have to excuse Manuela Brusemle, who was the second speaker of today. She is a parent of a CAH child and is a patient advocate in an EPAC in Endo-ERN, who has been extremely helpful for all of us. But due to some business reasons, she cannot attend today. But Heidi Klaassen is taking up some of her slides and her presentation. And so I'm very happy to introduce Heidi. Actually, I don't have to introduce you. You are a very kind and wonderful person, Heidi, first of all, but you are also an expert in DSD and especially in CAH. Heidi is a professor of pediatric endocrinology and leads the respective department in Nijmegen. She has been extremely successful in research. Just review some of the papers in endocrinology or European Journal of Endocrinology, which leads right to the topic of today, which is the gonadal function in males with CAH. Heidi actually has been very much engaged in Endo-ERN, and I'm very hopeful that she will do so even more in the near future. So Heidi, I think the floor is yours to tell us about gonadal function in CAH in males.
Yeah, thank you, Olaf, for this nice introduction and a very warm welcome from myself to all audience, all participants. And I'm very happy that I can discuss with you one of my favorite topics, this gonadal function in congenital adrenal hyperplasia. And this is the agenda of today. First, we will discuss a little bit more background about congenital adrenal hyperplasia. And then we go further with ovarian dysfunction and testicular dysfunction in females and male CAH patients. And we close the session with some summaries and recommendations for clinical practice. And I hope that we can have some discussion about your experience and your questions about this topic.
And maybe, Heidi, if I can just say a word, because I forgot it in the beginning. If you have urgent questions, you can place them in the chat, and I will read them in the meantime. So sorry to interrupt you, but I forgot that.
No problem. Good addition. So first, a little bit more background about congenital adrenal hyperplasia, and I'm sure you all know about this rare condition, this inherited condition that is caused by an enzymatic defect of one of the enzymes involved in adrenal steroid synthesis. And we are today talking about CAH due to 21-hydroxylase deficiency. And as you can see here in this figure, 21-hydroxylase deficiency leads to cortisol deficiency, but also to a lack of aldosterone in most cases. And due to the lack of cortisol, there is a lack of negative feedback on the pituitary gland, leading to a chronic stimulation of the adrenal gland by ACTH that is not suppressed by negative feedback of cortisol. So in contrast to other adrenal conditions of adrenal insufficiency, the hallmark of CAH is not only a cortisol deficiency and aldosterone deficiency, but a huge accumulation of the adrenal gland, leading to accumulation of not only ACTH, but also 7-hydroxyprogesterone and progesterone. These are the precursors before the enzymatic block, as you can see here, and they shunt into the unaffected adrenal androgen pathway, leading to a huge overproduction of adrenal androgens. So congenital adrenal hyperplasia is characterized by a lack of cortisol and aldosterone, but also to a huge overproduction of adrenal androgens, leading to this classical symptoms of virilization of the female genitalia, as you all know, or other symptoms of adrenal androgen production. And therefore, also the treatment goals are a little bit different, not only focusing on the treatment of cortisol deficiency and aldosterone deficiency by substitution therapy of cortisol and aldosterone, but also suppression of adrenal androgens. And we do that also with glucocorticoid substitution by giving glucocorticoids. ACTH can be suppressed, can be decreased, leading also to a decreased production of adrenal androgens. However, mostly supraphysiological dosages of glucocorticoids are necessary to reach this goal. And therefore, there is in most patients a balancing and a delicate equilibrium between undertreatment and overtreatment. Undertreatment leading to still some elevated adrenal androgens, with a typical symptom that you all know during childhood as precocious puberty, increased bone age with a decreased final height, acne, hirsutism, cardiovascular risk, but also impaired gonadal function. But also overtreatment due to high dosages of glucocorticoids, leading to other well-known complications such as obesity, hypertension, also decreased final age during adolescence, and cardiovascular risks. And today we will focus on impaired gonadal function, that is an important long-term complications in CAH males and females. So first we discuss the ovarian function in CAH females, and most of these complications is due to poor hormonal control. So elevated adrenal androgens that are not suppressed by glucocorticoids and elevated adrenal progesterone can lead to ovarian dysfunction. And this third cause can be ovarian pathology, and we will discuss these three causes separately in the next slides. First, we know that the mean ACTH is not significantly different in CAH and non-CAH female, at least when these females are under hormonal control. Regular menses is a very good marker for good hormonal control, because irregular menses is a sign of poor hormonal control. And we know that also from non-classic CAH, untreated non-classic CAH with slightly elevated adrenal androgens leads to irregular menstruation as one of the presenting signs. So menstrual irregularity is associated with poor hormonal control in CAH, mostly due to elevated adrenal androgens, but also progestins. So this adrenal androgen excess impairs ovarian function, mainly by suppressing the pituitary gonadal axis, leading to irregular or absence of menstruation. And you can see this here. So we have 11 elevated androgens, but also, as you can see in this next slide, adrenal overproduction of other androgens, the recently more described 11 oxyandrogens. So these are, for example, 11 hydroxyandrostenedione or 11 ketoandrosterone, as you can see in this figure from a publication published in Steroid Biochemical Molecular Biology by Auer et al. And as you can see here in this figure, elevated androgens, all sorts of androgens can lead to amenorrhea compared to those patients with a regular cycle that have lower adrenal androgens. So adrenal androgen overproduction of androgens is a very important cause of menstrual disturbances. But even in those patients with obviously quite good hormonal control with normal adrenal androgens, so normal androstenedione levels, there can still be a problem with menstrual cycle due to the excess of progesterone levels. Because in most patients we have slightly elevated 70-OHP and progesterone, even in well-controlled patients, but these progesterone can cause also menstrual problems due to inhibition of follicular growth and endometrial proliferation, but also failure of the endometrial breakdown. And we know this effect from those patients that use the mini pill, so progesterone, to suppress to regulate menstrual cycle. So besides adrenal androgens, also progestins are important in gonadal function. And you can see this very nicely in this case we published several years ago in a girl 15 years old with a primary amenorrhea. She was well controlled with normal androstenedione levels, but slightly elevated 70-OHP and progesterone levels. You can see this in this figure. The black dots are the androstenedione levels, and here so you see the 70-OHP and the progesterone levels. And we increased the glucocorticoid dosage every several weeks. And these patients collected saliva every day. And what you can see in this figure is that by increasing the glucocorticoid dose, the 70-OHP levels come down. And at some point, she got the first menarche here with lower 70-OHP levels, and now a cyclic pattern of progesterone suggesting a menstrual cycle. So with this longitudinal study, we could show that these progesterone levels are very important in the regulation of the menstrual cycle. And that means that increasing glucocorticoids is always the first step in treatment in patients with irregular menstruation. But of course, here the balance between over and under treatment is very delicate, and adequate monitoring and follow-up is necessary, preferable several time points over the day to look if there are elevated androgens also in several time points of the day. Besides elevated androgens and progestins, also ovarian adrenal rest tumors can be a cause of ovarian dysfunction, where the prevalence is low, much lower than in males. We come to that later on. The question is always, is it less frequent or is it more difficult to detect? Some smaller studies in CAH women using MRI and ultrasound did not show any ovarian rest, so the recommendation is not to regularly screen for these lesions. But we also know that it's difficult to detect. There are case reports that use venous sampling or PET-CT with ACTH stimulation. And we also know that there is a relation with adrenalectomy with consequently very high ACTH levels after the adrenalectomy. And I can show you one of our cases. Young woman, 21 years old, with classic CAH, with very poor hormonal control for years, with huge symptoms of adrenal androgen overproduction, with hirsutism and amenorrhea. And we decided to perform bilateral adrenalectomy to reduce the adrenal androgens and to improve the symptoms, and that worked very well. androgens went down and we could normalize the glucocorticoid dose. And you can also see this here in this figure, where you can see in blue the 70 OHP and in red the androstenedione levels. It went down after surgery and was very low, but after several years, the girl again, or the young woman again, developed symptoms of hirsutism and increasing levels of 17-hydroxyvorkestrone and androstenedione, suggesting that there had been some adrenal tissue somewhere in her body. And we performed ultrasound and MRI. We did not find any abnormality. And finally, we performed a venous sampling, and we could measure elevated androgens in the left ovarian vein. And indeed, we found ovarian rest tumors in the left ovary that had to be taken out. So in general, adrenalectomy is not recommended for adrenal androgen overproduction. But it illustrates very nicely the effect of strongly elevated ACTH and poor hormonal control, as is the case in this patient. So now we go further to testicular function in males with CAH. As you probably know, hormonal control in males with CAH is much more challenging than in females. And one of the important reasons is that they have less side effects of undertreatment, so they do not suffer from symptoms of adrenal androgen production. And that means that compliance, especially during adolescence, is a great problem. So poor hormonal control is very common, not only in adolescents, but also in adult males. But as in females, poor hormonal control severely impairs gonadal function and can cause primary hypogonadism due to adrenal rest development, but also secondary hypogonadism. And I will discuss this separately also in the next slides. So first, testicular adrenal rest tumors as a cause of primary gonadal failure, so primary damage of the testis. These are lesions that are described already for many years, and as they histologically resemble adrenal tissue, they were traditionally called adrenal rest tumors, the testicular adrenal rest tumors. They're often found bilaterally in more than 80% of males, of adult males, and they are benign, although they are not always very easy to differentiate from malignant Leydig cell tumors that can also be present in CAH patients, and there are some case reports described with Leydig cell tumors. But despite the absence of malignant features due to the central location, you can see this here in this ultrasound picture and also here in this MRI, due to the central location, the tumors can lead to dysfunction of the testis, especially dysfunction of Sertoli cells by obstruction of the seminiferous tubules, leading to azoospermia, and also to a dysfunction of Leydig cells due to damage of the surrounding testis. So as a consequence, TART will lead to infertility and finally also to irreversible damage of the testis, so a serious complication in CAH males. What do we know from these lesions? We know that these tumors have adrenal-specific enzymes, so CYP11B1 and B2 are present, as also adrenal-specific receptors, ACTH receptor and A2 receptor, and the tumors can also produce adrenal-specific steroids in tumor as shown by spermatic vein sampling. But as we found in the last years, these tumors also have Leydig-specific features, so they contain Leydig-specific enzymes, and that makes that it is still not clear what kind of tissue these tumors are. What we now know is that TART are similar yet not identical to adult adrenal tissue, and that they have a steroidogenic profile similar but not identical to adrenal, and that they contain cells with an adrenal testicular phenotype. So we're still searching in our research group for the etiology of TART. What are the treatment options in TART? Again, as it is correlated with a poor hormonal control, with high ACTH levels, increasing glucocorticoid dosages is the first step of treatment, and as also optimizing mineralocorticoid substitution. But of course, there are side effects: obesity, hypertension, striae, and cardiovascular risk profile. So also again here the balance between under and over treatment, and a good monitoring of adrenal androgens as well. Future perspectives can be CAH antagonists that are now currently here studied, or chronocort that will lead to a probably more stable hormonal control also during the night. But there are not big studies that show a positive effect yet on TART. So these are future studies that have to be performed. Testis-sparing surgery is not recommended, that testis-sparing surgery can lead to additional damage of the testis, and therefore cryopreservation in males with TART is recommended. So please refer your patients to a urologist to discuss this point, preferable in an early stage. Secondary gonadal failure in CAH males can also occur, also due to poor hormonal control. Again, elevated androgens that are aromatized to estrogens can suppress the pituitary gonadal axis, but also steroids produced by adrenal rest tumors may contribute to the suppression and the hypogonadotropic effects of progestin that we discussed already in females with the CAH. And again, one of the biggest problems is that there are no complaints from testosterone deficiency due to the contribution of adrenal androgens. So most males that with poor hormonal control produce enough testosterone from the adrenal cortex to compensate for testosterone deficiency and secondary gonadal failure. So how to evaluate gonadal function? That is really challenging also in male patients. Usually we measure testosterone, we measure SHBG, we measure gonadotropins, and we measure inhibin B. But in CAH patients, the testosterone production can be due to an adrenal origin, and therefore it is recommended to use the androstenedione testosterone ratio. Androstenedione testosterone ratio of above 1 suggests that the testosterone is mainly of adrenal origin. So a low androstenedione and a low androstenedione testosterone ratio means good hormonal control and a normal gonadal function. So a testosterone concentration within the normal range does not mean that there is no gonadal failure. Furthermore, SHBG can be used to evaluate gonadal function and to interpret the testosterone concentration. But again, as you know, SHBG can be influenced by several factors, as for example, obesity. In obese patients, SHBG levels decrease, so this has to be taken into account when using this parameter. Also, gonadotropins are not very helpful in evaluating the gonadal function in CAH, and as you can see here, one of our publications, you see here typical examples of patients with poor hormonal control with low LH and FSH levels, so suppressed gonadotropins, but normal testosterone levels from the adrenal origin from adrenal glands, with high estrogen levels that suppress the pituitary gonadal axis with high androstenedione, so androstenedione testosterone ratio of above 1, and very high ACTH levels, and also a high renin level. So that means that this patient has secondary gonadal failure, but with normal testosterone levels. And here you see patient with a good hormonal control, but with severe signs of primary gonadal failure, in this case due to testicular adrenal rest tumors, and also with a low testosterone level as a consequence of also Leydig cell damage. So you can see that measuring gonadotrophins, especially LH, is not very helpful in evaluating gonadal function. We usually use inhibin B as at least as a Sertoli cell marker. So poor hormonal control is the most common cause of gonadal dysfunction in males. I showed you two causes of gonadal dysfunction. First, the primary gonadal failure due to caused by adrenal rest tumors, leading to obstruction of the seminiferous tubules with Leydig cell function and Sertoli cell function, with usually elevated LH and FSH, but that can be also suppressed by elevated androstenedione levels that are converted to estrogen levels, and elevated estrogen and estradiol with suppression of the gonadal axis. Two reasons for gonadal dysfunction, and that can be both present in one person. Mostly secondary gonadal function is reversible by improving hormonal control. And you will find an overview of all causes of gonadal dysfunction in the paper that we published 2 years ago in the European Journal of Endocrinology, where we summarize all these causes and hormonal findings and the recommendations. And that indeed brings me to the summary and the recommendations for clinical practice. So I hope that I could show you that optimal hormonal control is a key for adequate gonadal function in CAH already during puberty. In all patients, evaluate hormonal control by regular measurements of adrenal steroid precursor through the day. In females, we assess regularity of the menstrual cycle during every visit as a good marker for hormonal control. And when irregular menses is present, measure androstenedione, 70-OHP, and progesterone. In males, we recommend yearly evaluation for the presence of adrenal rest tumors using ultrasound in classic CAH from pubertal age, so 10 to 3, and the yearly evaluation of gonadal dysfunction by measuring LH, FSH, testosterone, and inhibin B, and calculate the androstenedione and testosterone ratio. And when TART is present, referral to the urologist is recommended, including semen cryopreservation. And this brings me to the end of this presentation. So take care of your gonads. I say this always to my patients, especially to the adolescent males who do not have any problems, even when they have poor hormone control, but they have to be aware about the long-term complications that can develop. Thank you for your attention, and I'm happy to answer your questions.
Yeah, thank you, Hedi, very much. I was intrigued by your presentation because I was not aware that you could have a suppression of the gonadotrophins by oestrone. And today I just saw a patient with CAH who's actually taller than I am, so he's growing very well. I don't have the whole values in here, but the bone age is appropriate. He is an overprotective mother, but he doesn't get into puberty. And we were just doing a buserelin test today to see if he has two conditions. But when I looked at him, he had a phenotype that was a little bit obese and breast development, and he doesn't have any TARTs that we know of, and he's rather over treated, but still he's tall, but he doesn't get into puberty. I've never seen such a case. So I will review your papers and go into this and might ask you again. I'm looking into the audience if there are questions, and maybe in the meantime, the things that come from the patient side, would you emphasize again why, how we can convince the adolescents to adhere better to therapy? I think this is something that Manuela was also referring to, and I think she would stress today. So one thing is that we look after the patients, but how can we convince them to look better after themselves?
Yeah, this is a challenging task, especially in adolescent males, because, as I mentioned, they have totally no complaints. You cannot convince them, and they don't think about future, right? They think about today, and that's okay. But in the meantime, serious problems, and such as, for example, a very low inhibin B level or a suppressed gonadotrophins, as you mentioned already. So this is one of the topics that I discuss during every visit. So you do it not only for your current well-being, but also for future things. And they know that they get a yearly ultrasound from the testes, and I show them how to palpate and how to investigate their testes. And hopefully this is the message that they get from us.
I mean, one thing that you didn't go into, if you have these, let's say, adherence problems, or you're not so happy with the outcome of the patients, you said you have to adjust the therapy, but you didn't get into compounds. Would you recommend to the audience that we use more slow release hydrocortisone treatments, which are now available, I think, in Europe? In several countries, and would you promote that, the availability of slow release corticoids?
Yes, FMOD is now available in several European countries, also in Germany and the Netherlands, and we put some patients on FMOD already, and they really like it because it's a 2-dose treatment. But there are still no studies in adolescents. This is the first thing. There are not yet convincing studies about the development of TART, so that has to be done because this needs some more long-term studies. So the effect is still, I think, for the adolescents have to be studied in the next years. But yes, many of my adolescents, especially the boys, like that because they can use it.
Yeah, we were thinking about it today also in our patient. Despite we don't have anything where we know it's going wrong, but maybe it's going better. And I mean, this is something I was asking the question because this is, of course, something that Endo-ERN could be extremely helpful because we are having the healthcare providers which care for these rare patients. So a questionnaire or a survey within the Endo-ERN community could maybe be helpful to address these questions in the future.
Yes.
I don't see anybody talking to us, so it's more or less a discussion between us, but I think
there is a question.
Oh, okay. Where do you see the question? Give it to us, please.
So the question was from Loretta Iona Kostaki. And the question was asking about your opinion for dexamethasone as a treatment for TARTs.
Yes, thank you. Good question. Dexamethasone is used and is also described in several papers. We also use it sometimes, but we mainly use it in males that want to achieve pregnancy because of the severe side effects that the patients develop. So the striae, the overweight, and most patients are only motivated to use dexamethasone when they want to achieve pregnancy. So we don't do it in adolescents and in young adults when there is no fertility question. But yes, it is very effective in suppressing ACTH. Yes.
Yeah, but again, that is a very good complementary question to my previous question. We need to study much better the possibilities that we have now with other preparations, because dexamethasone is also not liked very much by the adult endocrinology community, I gather. So very good question, and we have to survey in Europe what the availability of the different compounds is.
Yeah,
I'm just going through.
The thing is really the ACTH. So the suppression of ACTH is difficult. We have to use supraphysiological dosages of glucocorticoids that give a lot of side effects. Dexamethasone can effectively suppress ACTH. But another development are the CAH antagonists that are currently under development, that specifically suppress ACTH, and that is, I think, a promising development, especially for CAH patients, to suppress ACTH. Then we can use normal dosages of glucocorticoids without thinking about elevated androgens. At least this is the hope. But there are still ongoing phase 2 and 3 studies, so we have to wait for that until we can make final recommendations.
I mean, the recommendation that Manuela wrote down in her paper that she had sent to us prior to the session was, of course, education, so that we really offer structured training courses, especially to young adults and adolescents, to inform them about the risk, especially for improvement of fertility, she writes in her paper. And I think you have stressed that already. So the definition of centers of expertise, the regular training and education, plus the use of modern medications, I think is the way to get better control of the condition.
Yeah. And the other thing, just as an addition, is that early good hormonal control is very important factor in the development of TART. We just published a paper where we used the ACTH registry to learn about the hormonal treatment in the first 4 years of life, if there is a relation with the TART development, and we learned that the early treatment, for example, in those countries with neonatal screening and early good hormonal control, can affect the development of TART in later age. So that means that also, for example, improvement of care, better infrastructure, better care already during childhood infancy has a long effect on long-term complications, not only on growth. This is what we as pediatric endocrinologists see, but also for long-term complications such as gonadal function. So this is, I think, also an important task for us as Endo-ERN to promote worldwide.
Yeah, and do we have EU countries who still not have a screening program? I'm not quite sure.
The UK?
Yeah. Okay, so UK doesn't belong to, maybe that's the reason for Brexit. So, anyway.
But there are several countries also, developing countries, that have no neonatal screening and also not the infrastructure to do early diagnostic and treatment. So and even do not have any medication, hydrocortisone or fluorocortisone, and then these longer-term complications leading to infertility is very a problem. And infertility is mostly discussed during adulthood, but we as pediatric endocrinologists can even prevent such long-term complication when we try to monitor as careful as possible with normal or adequate hormonal control.
Great, thank you. There's some additional questions actually. Firstly, thank you from Loretta for your response. And also a note from Violetta Aitova that the availability of medications for CAH is something that the Endo-ERN EPAGs are also looking into at the moment. So this is something they might advance. If anyone is curious, you can contact them via our website. And there's a direct question. I feel it is somewhat answered in what you have already spoken about, Heidi, but Magdalena is asking that some endocrinologists switch treatment to dexamethasone from HC when adolescent or young adult finish growth process. You don't recommend this approach. I think she just would like confirmation.
Yeah. This is indeed what I hear also from the adult endocrinologist, because dexamethasone can be used once a day and prednisone can be used twice a day, but still hydrocortisone is the preferred dosage because dexamethasone has the risk for long-term complications. So in my experience, but I'm not an adult endocrinologist, dexamethasone is mostly used in those patients that want to achieve a pregnancy, at least in higher dosages. And otherwise, you can use it once a day by carefully monitoring blood pressure and weight. But yes, thanks for the additional information.
Great, thank
you.
you.
Do we have further questions, Emily?
Nothing further has come in just yet. Okay. And we have 3 minutes left in the allotted time for the webinar, of course.
I think we can. I think we make a point landing now. So I think I have to thank you, Heidi, for a wonderful presentation. Very clear, and the questions that we have are also to the point. There are now duties for Endo-ERN to work on screening, education, medication. So I think the goals are really set by your presentation and overall. So thank you very much for this very kind presentation. Emily, to you, thanks for a very good technical presentation here and for your help. And to the audience, of course, for listening, because we of course want to continue with this. So please, there is a short question now. This is your first time attending one of our webinars. If you say yes, please come again. If you say no, I expect that you are regularly attending the webinars, then please distribute that to your other friends and colleagues so we can all join in to make things better for endocrine rare conditions in Europe. Okay, Emily, you've got the question, and do you have answers already? Or yes. Is that later on up to us?
Thank you. I'll disclose it. The majority, it is not their first time, but we have a few first timers, so you are all very welcome.
Okay, so we'll get a broader attendance every time, hopefully. And okay. Thank you very much to everyone. Have a good evening, and we go a little bit more educated into the evening. Thanks a lot, Heidi. Bye-bye, everyone.
Thank you. Have a nice evening.